Okay, let's continue with it. So next next question, which is wrong regarding PKPD profile of azole groups? So to understand this PKPD profile, there is a very good infographic by February Podcasts. So these are the various azoles, fluconazole, itraconazole, voriconazole, POSA as well as ISAVU. So if you look at the adverse events, all of your azoles have one property in common, that is they prolong the QTC, except for ISAVU, which shortens the QTC interval. Next, when you look at the enzyme inhibition, fluconazole has by 2C3A4, itraconazole and voriconazole have greater interaction when compared to other azoles, and voriconazole has the maximum interaction and also has P450 interaction. And then if you look at that metabolism, all the azoles are metabolized mainly by the hepatic, except for your fluconazole, which has more of renal elimination, and that is why among the azoles, in a case of UTI or when you are suspecting lower UTI, the drug of choice will be fluconazole and not the other azoles. So let's look at the options. All azoles except fluconazole are metabolized by liver, and caution is warranted when used in liver failure. Yes, true. All azoles are metabolized by cytochrome P50 enzyme and thus have significant interaction. Yes, because of the CYP inhibition, there will be a lot of interactions, especially with the common drugs like rifampicin and your immunomodulator drugs, tacrolimus, etc. Next, voriconazole is a drug with most interactions. Yes, and all azoles are associated with cardiotoxicity due to QTC prolongation. This is the wrong option. So this is the correct option for this question. Next, identify the antibiotic based on the following clues. So let's look at it. First, it works against MRSA, pneumococcus, enterococcus, but not against viridans. No activity against C. diff. So which has a C. diff action in amongst these? Your vancomycin has some action against your C. diff. Next, let's look at the other points. It can't be used in pneumonia and cannot be co-administered with the statins. So these are the greatest giveaway. So if you look at no action against viridans, again TICO is ruled out because this TICO as well as linezolid, it have good action on viridans as well. Dapto is the one which has significant interaction with the statin due to HMG CoA synthesis inhibition, and also this daptomycin can't be used in pneumonia because they are inactivated by the statins. Next question. 28-year-old male underwent appendectomy on 23rd of Jan, and post-operatively there was no fever episodes. His HB was 12, TLC was 10,000, platelet 1 lakh, and post-op day 3 there was minimal oozing from the site, and wound swab shows Pseudomonas aeruginosa, which was pan-sensitive. So what should be your next step? So again, Pseudomonas aeruginosa is one of the common organisms which can easily colonize. It is a discharge from post-op day 3, and there is no fever spikes, and this is a minimal ooze. So you need to do whether you should start injection ceftazidime. First we need to rule out whether it is a colonizer. So you need to repeat the culture. Is it enough that you just repeat the culture? Again, this is a wound swab. So ideally wound swab is not recommended specimen. So we have to repeat the sample at a proper collection of the sample. Discharge should be done in a sterile container, and this can be considered as colonizer, and you have to do the USG abdomen just to rule out any underlying SSI. So both C and D. So the option is correct. Next. A 22-year-old male presents with probable anaphylactic shock managed in ICU. IJV line was placed due to the failed peripheral access. He was completely asymptomatic on day 3 with some raised TLC, and to rule out if the shock was due to sepsis, a blood culture was performed on day 3 which grew pan-sensitive Candida albicans. So what should be your approach? So there is a difficult to place So there has been a IJV line, so that can be one of the risk factor. But in 3 days colonizing, doubtful. Again, just raise TLC. Otherwise, the patient is in actually anaphylactic shock rather than the septic shock. So whenever there is, so this could be a CLABSI. So in CLABSI, whenever there is growth of either staph, candida, we will have to remove the catheter. The first and foremost rule is we have to get the central line or the catheter out. So obviously we have to remove the central line. It's a contaminant, so you do not do anything. Remove central line and start him on fluconazole and look for other source of metastasis. Remove central line as it's not needed and start him on injection Caspo and look for other sources of metastasis. Yes, we have to remove the central line, but apart from that, we can't just rule out candida as a colonizer or a contaminant. Just like staph, as I've explained in my previous webinar, candida is one of the important pathogen which you can't just rule out. So you need to repeat the culture, remove it, and we have to while awaiting the cultures we should start him on an antifungal. So it is a pan sensitive, so you can as well give fluconazole. There is no need to give caspofungin if your fluconazole is sensitive. So if the patient has suspected candidemia and you do not have the species or the sensitivity, the drug of choice is caspofungin. And one important thing, whenever there is candidemia, we have to rule out other sources and metastasis. And if you are starting the patient on caspofungin, it is important to rule out your endocarditis by 2D echo, as well as doing the ophthalmoscopy to rule out chorioretinitis. Why? Again, because caspofungin does not have good penetration into your the vegetation, eye, as well as the urine. Next question. A new renal dialysis unit is scheduled to be built on the site of an earlier recreation club, which will be demolished first. The site is next to the block containing hospital's hematology patients, inpatient and outpatient. Which of the following is true? So let's examine one by one. Nothing need to be done. Obviously this can't be the option. Insists that contractors use external waste disposal chutes when gutting the upper floors of the building to be demolished. So when we use an external waste disposal chutes, this will disperse the fungal spores to a larger area. So what are the risk factors of having a demolition or any construction unit near an hematology inpatient, where the patients may be having some hematological malignancy and HSCT? So most common thing which we are worried about is the aspergillus. So first point, oppose the development and say it is likely to put immunocompromise at risk for aspergillus related condition. Again, this can't, ideally this has to be done, but obviously you can't oppose an development. So what can be done is ensure ventilation ducts, indoors water pipes are isolated from the area where the demolition is taking place, and create a list of areas with an at-risk population. So once you can allot an area for these patients such that they are away from a bit more away, and the ventilation windows and water pipes are separate from the area of demolition. Next question. A 44-year female presents with left-sided hemiparesis. CT shows space occupying lesion. 5 days into the admission, she deteriorated and required ICU admission. MRSA screen swab was negative. VP shunt was placed. 3 weeks later, she shifted to the ward, and 48 hours she had fever spikes and a drop in GCS. Her CVS and RS examinations are unremarkable, with small blistering on the right forearm near the cannula. What empiric therapy antibiotic would you like to start? So what are you dealing with in this condition? So basically this is a patient with who has come with left hemiparesis. Initially she was in ICU, shifted 3 weeks she was in ICU, then shifted to ward, and now you're seeing that the patient is having fever spikes and a drop in GCS. So that as well could have been due to the initial lesion, but fever is not explained by that. And also you're seeing some small blistering on the right forearm near the cannula. This is suggestive of thrombophlebitis. So whenever we are seeing a patient with fever, it is necessary to do proper head-to-toe examination so that you don't miss such obvious finding. And we have also seen a patient developing like infective endocarditis secondary to this. So it is necessary that you have to suspect the staph infection whenever we are seeing such a situation. So what is the empiric antibiotic? Something which covers staph. So her MRSA screen swab was negative in ICU, but again she has been in ICU for 3 weeks. Post that there has not been repeat of the MRSA screen. So ideally whenever we are covering for empirically for skin and soft tissue infection, and also she might as well be in sepsis because fever is also present, so we have to give vancomycin. Ceftriaxone can have some cover against MSSA but not against MRSA. Meropenem, as we all know, the carbapenems have some coverage but minimal coverage of MSSA. Clindamycin is a good drug, but again in this patient when we are suspecting sepsis as well, ideally this way, and also it will there is higher resistance reported as well as there is no action against the MRSA. So vancomycin is the correct answer. Next, a ER in tertiary care hospital noted that since 1 week, around 15 MBBS students were reported with symptoms of gastroenteritis. The following day, another 10 students are reported with similar complaints. There was suspicion of NTS outbreak since one patient had stool positive culture for a non-typhoidal salmonella. In order to prevent further outbreaks, which preventive action is correct? So first option, let's go one by one. Consumption of milk does not cause NTS outbreak. So meat is the most common cause, especially your shawarmas. So this has been linked to the salmonella as well as NTS outbreaks. Dry and cracked shell should not be discarded. There are reports saying that even the intact eggs with intact shell also can be a source of salmonella. So obviously we'll have to discard the cracked eggs. Food handler infected with NTS should stay away from work until they have been free from diarrhea for 48 hours. Yes, we have for food handler it is 48 hours, and for a student or a patient it is 24 hours free of diarrhea. So obviously all of the above is wrong. So the correct answer is food handler 48 hours. Next, a 73-year female type 2 diabetes was admitted with CVA. During the hospitalization, she was catheterized. 3 weeks later, her relative noted turbid urine in the urobag. Urine routine microscopy showed plenty of pus, and urine E. coli is showing urine culture is showing E. coli which is resistant to meropenem. So this is a CRE or carbapenem resistant E. coli. What antibiotic will you start? Will you start her on colistin, which is reported as I? Will you start fosfomycin, though it is not reported? So this is a common situation one will find oneself in. So most of the ICU patients will be on long-term catheterization. So every day of catheterization will increase the colonization of bacteria by 3 to 7%. So each day there is additional bacteria which is getting colonized. So by 3 weeks, if the catheter has not been changed, the catheter as well could have been a hub for all the colonized bacteria. So this is mostly a colonization. So we need to change the Foley's catheter. That is the first step. And in case you are still suspecting, repeat the culture after removing the catheter. So option C is the correct answer. 42-year male with history of lithotripsy, bilateral DJ stent for bilateral ureteric calculi, presents with features suggestive of sepsis. He had received multiple antibiotics and presently on colistin and meropenem. CT abdomen was suggestive of multiple calculi which is still present, and bilateral hydronephrosis due to the obstruction by the calculi. Patient underwent pyelolithotomy, that is source control they have done, with bilateral DJ stent removal. Good. So urine culture now shows growth of Candida krusei. Awaiting the susceptibility, what antifungal will you like to start? So will you give fluconazole, amphotericin bladder wash, voriconazole, 5-flucytosine? So to understand this question, it is necessary to remember the various intrinsic resistance. So Candida albicans is like though there is increasing resistance, but there is no intrinsic resistance. Glaberetta, as we all know, has slightly higher MIC for fluconazole. Cruci is intrinsically resistant to your fluconazole as well as 5-flucytosine. Candida parapsilosis has higher MIC for your echinocandins. Guillermondi also has higher MIC for your fluconazole. Norvengenus and inconspicuous are having intrinsic resistance to your fluconazole as well as 5-flucytosine. Your kefir has higher MIC for 5-flucytosine. Your Cryptococcus neoformans is intrinsically resistant to your echinocandins. And one more important, especially in urine isolates, is your trichosporon. So these are again intrinsically resistant to your echinocandins, 5-flucytosine as well as amphotericin B. So important things which you need to know, especially when you're handling Candida, is the intrinsic resistant to fluconazole, Candida cruci, Norvengenus, inconspicua, Candida auris, trichosporon, geotrichum. So 6 important ones which you need to remember. Intrinsic resistance, so amphotericin B, you are obviously trichosporon, and higher MIC is reported in Lusitianae. And 5-flucytosine intrinsic resistance is seen in case of your cruci, Norvengenus and inconspicua, including your trichosporon. So getting back to the question, so what you will use? Fluconazole? Obviously no. Amphotericin bladder wash, will just a bladder wash be sufficient in this patient who is having frank sepsis? No. 5-flucytosine, again we saw it is intrinsically resistant. In these options, voriconazole is a better one, though the concentration, urinary concentration of voriconazole is quite less, but in this patient, voriconazole can be used because the patient is in frank sepsis and it is a higher, so it is the pyelonephritis rather than the lower urinary bladder which is involved.